Keeping in on the theme of watching MBC in practice, we're going to move to some activities that Sheppard Pratt in Maryland and elsewhere has been involved in. And we're going to hear from Jeff Richardson, who is the Vice President and Chief Operating Officer for their community programs, as well as Dr. Robert Schloesser, who is the Associate Chief Medical Officer, Medical Information Officer at Sheppard Pratt, and involved in their point of care MBC project. So Jeff and Robert, you're on.
Thank you very much. If we could move to the next slide, please. Next one, please. I'm actually going to do the best job I can do, which is introduce the expert in this for us, which is Dr. Schloesser. But really quickly, most people know who we are, but we have, Sheppard Pratt has a range of behavioral health programs across the state of Maryland, 160 programs across 16 counties, 80,000 patients a year. And during COVID, we've delivered over 500,000 telehealth encounters. And we have continued to grow throughout the pandemic. And measurement-based care, and specifically patient-reported outcome measures, have been a key part of our ability to inform practice. And I look forward to the conversations going forward about implementation. But we're very lucky to have, next slide, please. This is just a very quick review of the programs and services that we have. And the only reason I think this is important for you to see is that we intend to use our patient-reported outcome measurement tool, not just in an inpatient or in a traditional outpatient therapy. We're using it across a range of treatment modalities, locations, and programs and services, from housing to home-based care to schools, and a range of populations. And so I'm going to hand things directly off to Dr. Schloesser, who has done an amazing job setting this up and can give you more detail on where we are with our program. Robert?
Yeah, thank you. And thanks for inviting me to speak about this. As Jeff said and showed, we are a pretty large healthcare system here at Sheppard Pratt, and with a very comprehensive continuum of care. Next slide, please. So I came from the research field. I'm the Associate Chief Medical Information Officer, but I'm also the Director of Point of Care Research and Innovation, as we call it at Sheppard Pratt, and I'm a practicing psychiatrist. So I mostly see patients in outpatient care. And I also teach residents. So I have like 3 different perspectives on this. In 2018, we decided to really make measurement-based care and patient-reported outcomes at the point of care like a focus here at Sheppard Pratt. And my team, which was originally founded as a joint venture translational research institution, really kind of started focusing on this. So we have a designated team here to facilitate measurement-based care. We have over 10 active programs. It always depends on how you slice it and dice it. The goal is to do it at 100% of Sheppard Pratt, but really the goal is to figure out like, how we can create a win-win-win situation for the patients, the providers, and basically the whole healthcare system and health system as a whole. We had over 13 programs before COVID. Then COVID changed some of the ways how things are set up. But the most of the programs stayed active because we were actually able to integrate our tool and our technology into telehealth. And we're actually deploying most of the telehealth appointment reminders and information through our system. Next slide, please. So I think these were all very great presentations today. We heard all the important things. There's very important themes, and I firmly believe in that measurement-based care is the future and has to be the future. And when you start getting into this, again, I'm come from the research field, but I'm also a psychiatrist. I'm very research oriented though, so I always envisioned something like this, which allows the patient to provide data in a very high quality way, like almost like research grade quality way, and it's very convenient, yeah, and then allows the provider and to utilize the data, ideally improves the communication with the patient too, you know, in a nice way, so that I do firmly believe, and have seen it myself, that this is you know, what we see in the research literature. I think from personal experience I can back up that this can work. I would say there's more unknowns still to make this really work. So it starts with this, and I think you know, something like this is the goal. There's always two kind of aspects to this if you think about implementing something this, especially at a large scale, in a perfect sandbox environment like Sheppard Pratt is. So there's always the collection part and then the utilization part. Next slide, please. The issue is that this is actually what you're facing when you're trying to do this, or this is my experience for the most part. Now, it's not as bad as it looks here, but the collection of this data is, you know, like it's challenging, especially if you want to collect at a large scale. Staff that's involved at you know, our healthcare system, you know, and that's the same probably throughout the whole mental health care environment, right? Like we are already overburdened, you know, we are not getting, I mean, the reimbursement is not high enough. That like everything's pretty challenged, and there's little resources. So integrating collecting of like patient reported outcomes at the point of care in a busy environment, it's challenging. The providers can't really, you know, do this. Some, I mean, and some are doing it on paper, pencil, or with simple forms in the EMR, but this is not very practical. And second part, the utilization, right? This is like what you face, like including me initially, you know, how do I access the data? Where do I get it? How is it, you know, how is it reported? Can I interpret it easier? Ideally, I would want to have tools that help me with clinical decision making, but of course not, you know, since we don't know enough yet, not in a too standardized kind of like simplistic way, because there's always exceptions. I mean, we're in behavioral health and psychiatry. It's very complex patients that we're treating. Yeah. So, and then same thing for the patients, you know, if you try to work with the patient and utilize this data, well, there's, you know, how do you do this best, you know? So next slide, please. So we basically knew that like the biggest things that we face if you want to be successful in creating a system where we can really successfully implement measurement-based care and make it really work with high fidelity. And the most important things is that we have to decrease the burden in workflow, time, effort, and that we have to increase the clinical utility, making the data relevant, current, available, and interpretable for the providers. And of course, this is all based on research. And you see these themes have been, you know, predominant themes also in these great publications from, you know, coming out from Kennedy Forum and the most recent one. Next slide, please. So our approach and the way that our team is organized is we basically have a measurement-based care team or facilitation team, which is the point of care research and innovation team, and we are supported by a group that we call digital services or data management group, and we have like kind of a quality improvement plan, do, study, act cyclic process where we engage the stakeholders at the point of care, predominantly the providers and clinic administrators, and not as much yet the patients. That's something we want to do going forward. We want to do this more, but we engage them in repeating quality cycle feedback and audit and feedback sessions where we learn what's working, what's not working, and our facilitators bring this back basically and create databases based on implementation science, specifically the REAM framework, where we kind of categorize things and measure things related to like the different aspects of implementation, reach, adoption, effectiveness, etc. And we also kind of catalog these modifications and adaptations in different like FrameIS and other scientific kind of implementation science models, with the goal to achieve optimal workflow, very fast feedback of not just the patient-reported outcomes themselves, the data itself, but also how the implementation is going. And through this, we want to, really kind of generate continuous learning about measurement-based care. And with the end goal to achieve real high-fidelity measurement-based care that improves outcomes. It's effective eventually. One thing that's very important is we have, we really align with the just culture, or, kind of frameworks of like, not putting any blame on anyone, because, when we first go to like a care team, we frequently really encounter a lot of anxiety and frustration about here's the next thing that we have to do, the next additional burden that might not, might not really improve our patients or our work experience. And it takes some time, but we have been very successful with this at Sheppard Pratt because we have these designated resources in the team. Next slide, please. So we have so far with the system collected patient-reported outcomes from over 10,000 patients. At the moment, there's 5,000 patients active in the system, and it's growing pretty fast. That means, we have a lot of programs that are time limited, inpatient programs and partial hospitalization programs. So that's why it's not, 10,000 patients that stay in the system. Half of them have been discharged. But we have about 5,000 patients that are doing this, for some of them since 2018 now in our outpatient programs, and over 25,000 just questionnaires collected. With variable completion rates, it's too complicated. I thought it's too complicated to demonstrate this data. We have some programs that collected 100%, but depending on, the frequency and the type of program, it can be lower. Like at the moment, a lot of the outpatient programs are around 50%. But that's because we also require a patient-reported outcome with every appointment, as long as it's not, it's more than 2 weeks apart. So sometimes people skip. When it comes to adoption, we use our tools to really try to look at like if our providers really utilize the system. We can do this by checking user activity in our system. If they log in, they don't have to log in a lot to do a lot of things because we have automated most of these processes, but they can log in to like check information pages, and a couple of things got cut off on the slide. I guess I made it in Google Slides, and this is a PowerPoint. We also track if the providers download the data into their EMR notes, and we can also track if they actually change the instrument selection, which they can do. There's a couple mandatory instruments, but some are selectable. So the higher the champions, the providers that utilize the system more frequently, they go into the system and click additional surveys.
Robert, so this is John Miller. Sorry to interrupt, but I know you're nearing the end, but we need to wrap up as soon as possible.
Yes. Next slide, please. Okay, so when it comes to effectiveness, this is my last slide. When it comes to effectiveness, we have yet not. This is not a research kind of setting or project, so we haven't really analyzed if if using it, using the patient-reported outcomes data is more effective than not using it. We can probably do this by looking at providers that utilize it more versus less, more in other ways. But we haven't done this. Now for short-term program level, we can display some of the improvements, which is very nice. And you can see this data here. So for like a program with a clear admission and discharge date, it's very nice to see this. We're working right now on better visualizations for programs that are much more long-term. All right, next slide. I think that just says thank you and gives my contact information. Anyone who has questions, please contact me.